Welcome to another episode of Leadership and Culture in Healthcare. I'm Matthew Wynn, the podcast host, and we're into a really interesting series on the independent health sector. And I am delighted to be joined by Keith Klintworth, who is the Managing Director of Vitality. Keith, welcome. Why don't you tell everybody a bit about yourself and maybe how you became involved in Vitality and leading up the UK elements of what they do?
Sure, Matthew. Thank you. Thank you for the invite. So I've had quite a very interesting medical career, starting off in primary care, working for prisons, and then often working in a mission hospital. Suddenly decided the one area of that I needed to explore and improve my skills was in anaesthesia. And so I specialised as an anaesthesiologist, as we would define the term in South Africa, many years ago, and was fortunate enough to have a very varied, interesting anaesthetic career for nearly 15 years, mainly in cardiac and neuro, but also in critical care. And during that time, got involved with private hospitals, started a day clinic, and my entrepreneurial side started to kick in a little bit and started to explore what else I could do. I loved anaesthesia, I love medicine, but also tended to find it a bit boring at times. And I suppose anaesthesia has been like a pilot, it's 90% boredom and 10% sheer terror. But I just thought I would like to do something a bit broader. So came over to the UK in 2001 and did an MBA. And during that time was looking at exploring other avenues within healthcare. That ended up working on a project for the WHO in Russia on HIV/AIDS programs, which was fascinating. Anyway, I have a working, successful career partner, and we moved back to South Africa, and I started in doing what I was doing. But during my 15 years in private anaesthesia, worked with the private funders, and was always at the negotiating table representing anesthesiologists and anesthesiologists' interests, but also talking at conferences more on the practice side of running anesthesia. How do you run an effective practice? How do you drive quality of outcomes? How do you derive and deliver economic as well as sociological value to your actual patients? And during that time, met the founder of a large medical insurer in South Africa and Discovery Health. And Adrian Gore, an actuary by background, started this business of a medical aid. And I was just taken by his purpose of making people healthier. And over the many years of negotiating anesthetic tariffs with Adrian, but more importantly, understanding that you needed strategic relationships with your actual healthcare providers and partners. None of us are in a siloed ecosystem. We're all codependent on each other to deliver a successful and a sustainable healthcare adaptive solution for a country to make all people healthier. And I guess during that time, I started exploring that as an anaesthetist, I was quite limited in the impact I could make to people's lives. It was the patient and the immediate family, but actually gain more into a little bit of population and making a broader impact was what excited me. So when the opportunity came to move back to the UK, I joined them in their clinical risk department and started a clinical risk division of working with providers, building strategic relationships, trying to drive this agenda of quality of outcomes, and really just been a very purpose-driven for the first time in my whole career, in fact, that I was very clear on what I was here for. And for the last 14, 15 years, that's been pretty revolutionary. And the impact I can make as a doctor to a broader ecosystem.
And Keith, that's fascinating. Wow, you've covered some territory in your career, but it's fascinating though that you thought that your kind of value-driven focus would be with an insurance company or a private provider. So what kind of, how do you make a difference through that approach, and what is the value driven approach in the independent sector realm for you?
I think largely the independent sector in the UK is focused on employees. So, still by far the majority of private medical insurance in the UK is provided by employers, whether those are large corporate or small, medium enterprises. There's about 20% of individuals. However, within that, employee well-being, as we know 15 years ago, it was a tick box exercise of employee wellness, in my opinion. You offered private medical insurance to try and provide quicker access to treatments. But were we really focusing on stopping the funnel from the top? And it's a challenge NHS and any public sector provider has faced for decades. And focusing on prevention, but more importantly, a behavioural incentive program. All of us have bad habits. How do you change habits? And it's only through a behavioural incentive program, ultimately. It's got to be relevant. It's got to be personalised to you. You've got to know what your risk factors are. And by far the majority of us, I think, are blissfully unaware of our risk factors. Those of us who have smoked or have drunk or have eaten badly or haven't exercised, we justify it. Genetically, my grandfather lived till he was 90. He smoked his whole life. I'm not going to be affected by cigarettes. We've all been down this road. And therefore, by making people aware of their risk factors, putting them on a program to improve it, but more importantly, reward them for making a difference to improve their life. And what Vitality does, which is quite unique, is within the shared insurance model, where if you improve your health by doing preventative activities, in reducing and improving your lifestyle risk factors and managing your clinical risk factors, we lower your premiums or we lower your renewal premium, because we know morbidity and mortality is directly proportional to the risk factors that you incur, whether those are lifestyle or clinical. Let's help you make a difference and make a change. And what I love about this organization as well is that it is so analytical driven. No decisions are made without data. And therefore, for a customer, what are those changes you need to be making that I can model that actually improves your mortality or morbidity? And this is across our private medical insurance market, but it's also across our life insurance type of products. So if we can attract you, keep you on longer, keep you healthier, your claiming on critical illness or income protection or even death policies is put out into the future. But more importantly, I think through what data science is, through our models and what we create, is how long do I need to influence you and make programs relevant and personal to you to change your behavior? And we create a habit index, which, to break a habit, you need at least 7 to 10 weeks of an activity which becomes a habit. So walking, I don't expect you to all be marathon runners or Olympic athletes, but actually to get you into a habit from couch to 5,000 steps, that will take you at least 7 to 10 weeks to regularly walk 4 times a week, 5,000 steps, and then you will build on it. And what's fascinating with the whole behavioral model that we built and the activities that we surround everything around, it's physical activity. We know physical activity is actually the cornerstone of most things. Improves your mental health, cause and effect. Don't exercise, you get mental ill health. You have mental ill health, exercise reverses it. Eating healthily. If you are active, it's amazing how we suddenly change our behaviors and actually eat healthy. And by then becoming in tune with your body, actually, if you have comorbidities, you manage those a lot better. You take your blood pressure regularly, take your medication regularly, you manage your diabetes. All of those things come together. So it's a really fully encompassing preventative program, screening, appropriateness. But more importantly, on the other side is when you do get ill, and we all get ill, we're all going to have times of illness. How do I get you back to the best state of health that you can be? And for that, you also need a behavioural change program. How many of us have gone through major surgery and have just sat back and waited for things to improve? You'll do a little bit of physio, but actually it's about nutrition, it's about exercise, and it's about mental well-being.
Okay, so Keith, I'm sitting here thinking, well, new government is prioritising prevention, changes from analog to digital, and moves from hospital to community. And on the surface of it, that's exactly the job that Vitality have been honing through a data-driven approach for years. Would I be right in thinking that that's actually the core elements of what you all get up to as an insurer all the time?
Absolutely.
And
I
and so
think
if that is the case, and I'm intrigued to know what the difference between the general population that one would have to serve in the National Health Service, i.e. a universality, versus the cohort that you're getting, which are paying for their insurance. What's the crossover that you can see? What is universally applicable that actually we potentially could be learning from the Vitality approach, and what can't we learn given it's a payment model?
So in my opinion, I think getting people to understand their health, you can offer free health checks, which the NHS has done for a good number of years. The take-up of those remains quite low. You can, track, people can put in wearable technology, and you can link devices, you can proactively reach out to people. You can use AI to say to someone, well, you need to do X or Y. What we found worked for us, and that's been the advantage of an insurance model, is that I can pay you to do the right thing. So as an example, when we started here, when I came in 2010, we never had an activity rewards program. So you would link devices, you would do steps, you would try and get you up at different status levels. You would move from bronze to platinum by doing health checks and by linking a device and going to gym, etc. But it was only when we introduced the free coffee that if you unlocked X amount of points a week, which was a proxy for your level of activity, that released the free coffee, that released a free cinema code. And as bizarre as it sounds, actually we all need an incentive. And you might not even use the coffee, but knowing that you've attained something and won something is actually a strong motivator within humans. And how does the NHS do that? And, by framing things correctly, behavioural incentives, when you are working within a public healthcare system, which is free at point of service, how do you penalise people who are not doing what they should be doing or don't attend the appointments that they should be doing? It's really, really difficult. And therefore, does a £5 voucher change behaviours? Does something additional within this context of a free service at point of delivery? That's the challenge. And we've had many debates with government, with health institutions about how do you solve this problem? Because primary care within the UK is facing enormous challenges, not only from a resource perspective, but actually, it's either your frontline staff, which could be nurses or whatever, doing the more routine stuff. But how do you personalize and understand who actually needs that face-to-face behavioral with cognitive behavioural therapy or whatever, to change and inform and wake people up to the risks that they are exposing themselves to. And that's complex, and that can't be solved overnight.
So there's a reward and incentivization element for the individual, which of course then becomes frankly a governmental policy issue of, do they want to actually incentivize? I think that has been tried in various elements, and some success, but not others. I imagine, though, there's also, when you think about the people that you employ, your clinicians, you're also turning the model on its head in saying, we don't want to be intervening so much. We want to be intervening less. And therefore, our whole model is preventative. And therefore, actually, orthopedic surgeon, rheumatologist, heart specialist, actually, how do you then get around getting over to them as your employees or the people that you contract with, that actually, we don't want you to do lots of intervention, we want you to do the minimal, and that's the quandary that the NHS has alongside you in the private sector, I would think.
Absolutely, but I think it is broader than that. So if I think back to our primary care services and GPs, so in 2013 I went investigating how I deliver virtual GP services. And we eventually were able to kick that off in about 2014. And it was quite a quandary in getting GPs to buy into, in 2014, which is only a decade ago, of the benefits of virtual healthcare and whether it is possible. Not for everybody, but for 70% of conditions, it's more than suitable. But more importantly for me was making our Vitality GPs Vitality fit. So I don't want you just to prescribe and treat sickness. I want you to promote wellness. So therefore, sharing data, our customers, all of the stuff that they've done with their activity or done health checks or their preventative screenings or whatever, the GP should have access to all that information. And therefore, when they are talking to you about treating your sore throat or UTI or whatever condition you're presenting with, why don't you end the conversation by saying, I see you not doing much physical activity. Is there a reason for it? And this is the benefits of what exercise brings for you, by way of an example. And that's been quite a challenge to actually introduce. Then what we then did subsequent to that is that we offered the Vitality program, the program we offer to all of our members. We offered that to our GPs and all of our premier consultants, which are those consultants that we've identified who deliver superior quality of outcomes based on the data measures we have, looking at length of stays or total cost per events or readmission days or etc. We offer our premier consultants the Vitality program. And the rationale for that, when you live the program, do you prescribe the program? Is point one. The second one is, actually came back to the strategic partnerships with providers I alluded to right in the beginning. I have a vested interest to make sure the resource I am having to make available to our members, they've got to stay healthy. That includes my doctors. And I just don't think we spend enough on that. My observations of any healthcare institution, our nurses, our doctors, do we have a healthy workforce? And how do we support them in becoming a healthy workforce? And they then become great advocates in promoting wellness to customers and patients.
And there's a couple of things I want to dig into there. But first of all, just on this point about universal applicability, the model to the NHS, have you looked at how far you think your model goes into the general population for a group of people that aren't paying? Because I assume the ability to pay comes with a whole bunch of factors associated with it, and you're taking out potentially a whole bit of deprivation, you're taking about a whole lot of socioeconomic disadvantage. If you were to argue from your experience of Vitality, is the model applicable to everyone, irrespective of ability to pay? Do you think you have enough evidence to say yes for that?
Yes. And I think where the data comes from internationally, we in 40 countries, the Vitality program is offered as a standalone or in conjunction with other health insurance products in the US or in South Africa or in AIA or in Asia, for life policies as well as health policies. And when we look at as I said before, in the US, employers are the biggest funder of private medical insurance. They provide private medical insurance as a benefit. Now, we've always had the debate, just as we're going down this journey of ESG and sustainability, and that's been reported on your board reports, on your annual board reports. Why have we never had a board, including on the board report, of employee wellness? How are you as an employer actually evidencing that you are making or keeping your employees healthy? And when I look at the experience in the US, when you look at our own corporate data with our corporate schemes that we provide private medical insurance to, and the work, that we did with the FT, which we're still doing, we did it for 10 years, was Britain's Healthiest Workplace. We have so many data points in understanding what drives employees' presenteeism, absenteeism rates, how can we improve productivity? And it became the business case for why you could then go to the CFO or the CEO and say, here's the benefit case. Invest X in your employees, and this is the benefit you get through reduced presenteeism and absenteeism. Now, that similar model actually translates across everybody. If you want to drive productivity, growing your GDP, you've got to drive productivity growth within our businesses, which then funds all the ability to fund services for people who can't work or on other benefits that are needed. And that's really how the shared value model transpires more broadly. What's good for me, what good for me from you doing something healthy actually benefits society in the more broader term.
I mean, fascinating to look at that coming across. I was having the conversation with one of my directors this morning about turning our what I think is a fairly traditional occupational health approach with our staff in my organisations, one of my organisations, I should say, into a conversation about what are staff able to do, and then what would it take for them to be able to do something else when they've been unwell. And you're saying it absolutely, it's a rewiring of A, incentivizing them, and B, the whole mindset of approach of let's work on being great employees and great employers and finding the mutual side in that, isn't it?
Absolutely. I just look with our own staff all of our staff are on our private medical insurance, but on our corporate scorecard, which our bonuses are defined every half year, one of the measures is employee wellness. And because we have the private medical insurance and we have these status levels, we expect 60% of our staff to reach gold status. So you go from bronze to silver to gold. And all of that is reflection of your physical activity, or going to gym, aerobic, or just step activity. And, we hit our 60% target. Our staff are engaged, and they're not being paid anymore then for differentiating or discriminating against any of the groups. Even if you are someone with comorbidities, I can get you as healthy as you can be. But managing your mental ill health, managing the ergonomics of working at your desk, having step challenges within the office, giving flu vaccinations, all of the preventative measures, understanding your cancer risk, we do cancer risk scores, etc., etc. And we have coaches, and people talk about wellness, and this is pervasive throughout our organisation, which is really, really powerful. And that's
So I want to pick up on your support for your staff. So you've just given some great examples of how you've turned that in. But I think, and tell me if I'm wrong, you said an example of paying, for instance, I think you were talking about surgeons. You're paying them because on a gradated level according to the outcomes that they've achieved. Did I hear that correctly?
No. So in order to select, so the 20,000 consultants who do private work. Some of them do one case a month. Others do really regular sessions at least once a week. Some 10% are in full-time private practice. Brilliant thing about the UK is that I can generally be rest assured that by far the majority are really good. They're well trained. The GMC's appraisal system is robust. So how do I differentiate between the good and the excellent? And I'm driving for excellence. So I have all this data of outcomes, of people's experiences, customer reviews, which are important. How do I, as a member or a patient, choose a consultant? Many of them are on other patient reviews. You said about your bedside manner or timeliness or ease of making an appointment or being on time or whatever. But the other flip side of it is understanding, well, what are your readmission rates? What is your infection rate? What are the proxies I can use for that? So we've tried to create condition networks, whether that's hip or knee or spine or breast pathways. But how do I choose the consultants that I think are the best to keep the cost down? Because ultimately premium is reflective of costs of healthcare. And, there's always going to be waste in the system. And by managing the outliers and not the averages, let me clearly identify who are the outliers negatively. But the flip side of that is also identify positively those who are really cost effective. And let me create a network where I can channel people. And that's basically where it all started. And we've now built up, a significant number. We have 4,000 across different disciplines, regularly practicing private consultants doing private work, whether they're full-time or still employed with the NHS. And we track their quality of outcomes, their admission rates, their length of stays of average patients, case mix adjusted. So we're comparing apples with apples. And because from my perspective, I not only hold the role of managing director, but I'm also a responsible officer. And I've got to ensure clinical outcomes are delivered as best as they could be. And that was really the basis for why we went down this route. Because I want quality of outcomes.
Yeah. And does that mean consultants won't be used by you if they fall down below a certain threshold, or is it as binary as that?
It can be. So there are consultants that we de-recognise, not many, but you always have the couple that you need to be aware of and de-recognise. The majority of consultants are recognised by us, but we recognise a pool of people who are prepared to share their data of outcomes with us. So in order to sign up to the network, it's a two-way street. I will identify you and proactively reach out to you. But the reciprocal of that is you can apply. And if you share the data with me, get patient reviews that I can understand the touch points. If I have no data about you, I can't judge. So therefore, let me help you. Let me know how good you are.
So, no data, no job.
Basically, it's not quite like that. But
it's not quite your recruiting slogan.
No, it's not.
I can imagine. Yeah, but the essence is there. So I think this kind of starts to get into what Keith is the difference between independent healthcare, employment and support. I mean, you've talked about the support package of staff being able to access some of those, getting up to gold level, etc. But how else are you leading and setting a culture that is either very similar to the NHS or distinctively different in the way that you provide healthcare and commission it?
I think it ultimately comes down to innovation and speed of disruption. You know, working within any public sector is, it's a Titanic. You slowly moving things. When private healthcare and private provision of whether that's creating cancer networks specifically focusing on breast or colon or going down spinal networks or hip and knees, where the private independent service benefits is from guidelines and protocols that are set by the NHS or treatment prescribing practices overseen by NICE. We were able to take some of the real wonderful things that the NHS has built and created, not least of all multidisciplinary teams. And if I think back to private independent healthcare 15 years ago, hospitals would have clinical directors or proxies for MDT committees, but those are now far more alive and operating effectively than I think what they did historically. And it is ultimately about quality of outcomes. If I unfortunately get cancer, I want to know my outcome is at least equivalent to the NHS. And we've got to get better at that within the independent healthcare sector. Is actually evidencing and proving that outcomes and customer experiences, patient journeys are brilliant, as they should be within the NHS. We learn from each other.
Is therefore you looking forward, the NHS and independent healthcare pretty symbiotic? You've just mentioned you benefit in, I think I've heard you say 3 things where the independent healthcare benefits. One, a trained workforce and a regulated workforce. That's already happening. Secondly, standards. And thirdly, a framework of outcomes that actually have been set. And what I think I'm hearing is therefore you're building on that and making sure you're at least getting the best standards, if not better. Am I characterizing that right in terms of that relationship and what you try to achieve?
I think absolutely. You would have asked any independent practitioner and organization 10 years ago, are we a collaborator or we're a competitor to the NHS? And historically, collaboration has always been key. During COVID, the services and independent services have fulfilled. Ultimately, we all have the gain of making Britain, in particular in this case, healthier. And the things that I can do as a private medical insurer and transfer that knowledge onto the NHS and guide them, show them, it's a reciprocal arrangement. And vice versa. I learn a lot from the NHS. I've worked in the NHS. I've taken some good. I've taken some bad. And I'm sure many practicing practitioners in private look at some of this stuff and think, no, that's not perfect, and therefore I need to improve it. Availability, accessibility, critical care. Making sure you're properly selecting, that you're not just cherry picking, but actually offering a healthcare solution, albeit private.
I guess, Keith, you're now facing a different future. You've Vitality being public now that have got a successor for you, and you're at some point going to step down as a managing director and continue to advise and be involved, but go on through something else. So I guess you're in a good position to kind of think forward, because you'll be doing that for your own future. I'm going to ask you what you might be doing, just because people will be interested. But where do you think that relationship and symmetry could go? What's the opportunity? And I guess within that, if I could, what do you think is the independent sector's responsibility back to the NHS? Because I've heard quite a lot of you saying we're of benefit. You've obviously create capacity. you benefit from the structure of the NHS, whether that's NICE, training, everything else. What do you think in the future ought to be the reciprocal elements of the independent health sector? I don't know, paying back into that or being a different type of partner going forward? Where might that go?
So into my next phase of life, which I'm working on a 10-year timescale, is I would love to get more involved in insurtech, advising on boards. And I guess this is where giving back to public sector or giving advice or knowledge, innovation and disruption is easier in private sector. You can pilot and test things a lot easier and quicker. Speed to market, taking some of those positives and putting them into the NHS. Finding collaboratively a solution to electronic health records, which have remained a key challenge. It's all very well saying private shouldn't have access to NHS information. Well, it depends who you're talking about, private or independent. Independent practitioners, consultants, or GPs working in the independent sector, managing a private patient should have access to patient records. It's the patient's record, after all. But the reciprocal of that are things that happen in private need to be shared with the NHS, because people are going to find their way back into NHS pathways, either short term or longer term. So I think there's an enormous amount of work and collaboration that can happen in that space. And let's not minimize, and you're a chief executive yourself, the skills that senior execs from the independent sector can bring back into the NHS can also not be understated. But more importantly, in the independent sector, having clinicians at a board table and being the voice for those that maybe don't have the voice. And that is the one big observation that we notice with clinicians and nurses being in the independent health sector as chief executives and within the NHS is that we are ethical beings. The wonderful things about doctors is we don't realize we are being continually facing ethical decisions our whole careers. And it just becomes second nature to us. But actually, when things are exposed that you suddenly question, you are quick to raise that. And that's why I'm saying being a voice for someone that might not have a voice. And it's probably not saying independent sectors unethical in any shape or form, but you just bring a different bias, you bring a patient concern, you just bring another facet to the argument. And I think that benefits public and the independent health sector quite significantly.
Yeah, and some really salient points about that record is my record, it's your record, it's not someone's to tell you cannot do anything about it, and what's in there is important to my health. Why is it not used in the right way? That's a really important point, isn't it? So it sounds like we're going to see a lot more of you, Keith. But interestingly, I didn't hear putting the scrubs on and being an anesthesiologist again and being in a theatre. I heard lots of non-clinical world in there and bringing your expertise, which is absolutely fine. I think that's probably true, isn't it?
Well, in part, I have put my name down to go back to Doctors Without Borders, and I was quite clear that I'm not sure I'm ready to practice as an anaesthetist again. But you know what? I can definitely help in operational processes in the areas of need when we go into earthquakes and natural disasters. And in fact, I was still trained in the times we were using Schimmelbusch masks, which you might still recall with the ether and the halothane and whatever. So I still have some of those skills. It might not be levels of cardiac bypass surgery, but I still have anesthetic skills.
Still running through your veins, so to speak.
Exactly.
Well, Keith, it's been a delight getting a different perspective on life. I mean, that career across amazing W Health organization, your cardiac neuro world, and then that whole part that you've led over many roles, but lead in vitality, about the behavioural change for the person, incentivising it both for staff and the person doing it. Some really thought-provoking kind of elements in there about why that could easily be applicable across to the NHS, and the I think a really great challenge of why don't we report about the health of our staff. Everyone's a big employer, and actually our responsibility is to our staff, and we should be incentivizing that. And then how do we learn from the independent sector and get that grit, the innovation, the growth, the flexibility. And for one thing that stands out for me is that whole element of standards, data, use the right information to make good decisions. Keith, I guess the final question for me then is, what are you optimistic about when you look forward? And please don't say my retirement and moving into the next stage of life, because we take that as a given. But what's providing optimism in the healthcare world for you?
I think digital healthcare is just going to be unlocking a whole lot of opportunities together with AI that will drive efficiencies and improved outcomes.
Brilliant. Keith, thank you so much for joining me on the podcast. It's been really interesting to hear your insights, and we look forward to see where you materialize next in providing some of that information and knowledge onto another forum, and maybe hopefully somewhere in the NHS as well that will benefit. Keith, thank you so much.
Thank you, Matthew.